It's the 7-Minute Drill, a fast-paced and fun conversation about common orthopedic topics and solutions with Dr. John Urse. Brought to you by
Ted's Authentic Greek Salad Dressing and Marinade. It's healthy, gluten-free, and delicious. You can find Ted's in Dayton, Ohio at Dots Markets. That's Ted's Authentic Greek Dressing and Marinade. Thanks, Ted.
We would also like to thank
Stifel's GWR Group combines more than 65 years of experience helping high net worth clients consolidate, coordinate, and simplify their wealth planning strategies. The group has access to a full suite of resources to serve all of your financial needs. Email gwrgroup@stifel.com or call 937-353-2863 to speak to Guy, Brad, or Jeff Richardson. Stifel, Nicholas & Company, Incorporated.
Well, Dr. Urse, welcome back. We're here to talk about something that's cool, something that's hip.
That's right, Terry. Today we're going to talk about what is the best approach for a total hip replacement.
So first off, does everybody need a total hip replacement?
Absolutely not.
Okay, why not? I mean, I figured once you get old, those hips are going to go, everybody's going to have to get one.
Well, it's not true. If your hip is nice and smooth and well-rounded,
yep,
much like your attitude, your joints are happy. And when the cartilage, which is the cushion between the bones, wears down,
right,
that causes bones to rub on bone, and that leads to arthritis. Arthritis causes pain because bones have nerve endings. That's why a broken bone hurts. So when your hip wears down, and there's a few reasons it wears down in some people at earlier ages or later ages. One, from trauma.
Right.
Two, you may have what's called a shallow hip socket where it's not a good match between the ball and socket. You may have a square peg and a round socket. That's much like a hip impingement problem where something rubs against something. It tears the lip called the labrum. It can damage the cartilage in the socket. We're close to the spring NFL Combine, which for people around the world is our American football.
Yeah.
But it actually is real important for the teams to pick a player who doesn't have a hip problem. So they'll do an exam. They'll frequently do an MRI of a person's hip.
Right.
And they'll look and see if they have a bunion or a bump that makes that round ball look more square. If it's uneven in its appearance, that hip could be in danger for a surgery later that's going to take your $5 million draft pick out of the commission for a year while he gets it fixed or reshaped.
But do certain sports lend to getting a hip replacement more? Does golf?
Absolutely not.
Okay.
You can play all the sports you want. You can, I'm still playing baseball at an older age. So there's nothing wrong with your hips, knees, and ankles as long as they don't have trauma or injuries to them, or you aren't going to have something unfortunate like rheumatoid arthritis. We talked about gout,
right,
things that cause an arthritic condition to develop in a joint, much like battery acid and some of those areas where the inflammation in the joint gets injured without trauma, but by a chemical or a substance like uric acid, or in rheumatoid arthritis, the lining gets inflamed. So today we want to talk about why hips that are bad need to be replaced and what might be the best way to approach the hip. And there's going to be the same surgery done inside the hip once your surgeon picks the way to get into the hip.
See, I don't understand that. What does that mean, get into the hip?
Well, that's just like getting into a house. You can go in the front door, the side door, or the back door, right?
Which way's better?
I'm going to talk about that today. Okay. Today we're going to talk about the anterior hip approach. It's a newer procedure, but it has a lot of appeal to patients.
Wait, stop. What's anterior?
Anterior is the front. So we're going to talk about the front,
okay,
which is the front door.
Why don't you guys just call it the front?
Because anterior is an anatomical term. Your posterior would be called your rump. So a posterior approach is like a pocket incision. If you feel your rump in the back pocket,
right,
an incision back there is called a posterior hip approach.
Okay.
And there's actually a side approach from the side of the hip. Not as common, but it is something to mention, but we're not going to talk about today.
So what's the fancy word for that one?
It's anterolateral or a true lateral. On the lateral side, which is to the side. So the main thing to think about, though, is why would one doctor pick one approach, or why would you as a patient want to know how are you going to get into my hip?
I have no idea why.
Well, because it has to do with perhaps how much muscle damage is done, how to get in there, how much bleeding What is the risk of infection? What about the hip position after surgery? Is my hip going to pop out? So there's advantages to the anterior hip over the posterior hip for a few reasons.
So you're a hip guy. This is your alley. If you had an alley to go up, hip replacement is that alley, correct?
That and what's called hip preservation. So I also do hip scopes. So if your hip is misshapen and you're 30 years old, you don't need a new hip. You need to get to age 90 with the hip you have. So I'm going to reshape it. I'm going to smooth it over. I'm going to hopefully make that hip a better smooth ball and socket so an NFL team can draft you. But more importantly, maybe avoid getting a hip replacement. If you leave that hip misshapen, let's say you have a square peg and a round socket, they call that the silent killer in hip pathology, because you're just beating the heck out of your hip because a round ball fits better in a round socket, and a square peg in a round socket is going to abrade or scratch or hurt the cartilage, which is the gliding surface of the hip joint. So our job as care providers is to say, when does someone need a hip replacement? Well, if you look at your x-ray and you see that the bone is rubbing on bone, much like a knee or any other joint, the cartilage is lost, much like the brake shoes on a car where they grind and squeak and your car finally stops. You're like, we need to get some new pads. Well, your hip needs a cushioned surface also.
Okay.
And if you then say, well, just because my x-rays are bad, do I need a new hip? The answer is no. You may try some injections. We're going to talk about PRP and some of the stem cells and biologic options to delay surgery. There may be therapy options, weight reduction. We talked about that. And there are cartilage protective agents we do with some of the safe alternatives. Well, the gel's not approved, at least in the United States, for the hip. It is for knees. It's a lubricant gel. We'll talk a little bit about it later. But the main thing is, at this point, you can't walk well, you can't sleep, you can't shop, you can't go to a soccer game, you can't football to our overseas brethren, and you can't enjoy your life because of your hip. You're walking around like Winston Churchill with a cane. You don't want to look like an old man or an old woman. You therefore talk to your doctor and say, I think I need a new hip. My life is miserable. Well, at that point, you should ask, how are you going to do my surgery, doctor? And the doctor may say, I prefer the front or the back, which is the anterior,
because they have more
or the
expertise
posterior.
with that.
Or they have certain, not only expertise, but the equipment to do it. The ability to do the front hip incisions is a newer procedure because the tables allow the leg to drop down to let you put the implant in. And we have a little model of a picture.
I was playing with that earlier, yeah.
You're allowed to play with models. So this shows a hip, and the thigh bone is this, and I'll just take it apart. So your thigh bone gets the ball taken away because it has arthritis. We put a new thing called a stem into the bone, and it's usually...
Is that a real thing?
This is a real implant, and then we machine and fit this in very tightly, and that's called a press fit.
You drill a hole in my bone that big?
Well, we open it with little opening, they're called reamers or broaches, and they literally machine this until it's tight and snug, and then it has a spray on there that's sometimes used to help the bone grow into the implant, so we don't need bone cement,
really,
which can crack like your bathroom tile after 10 years. Now, there's nothing wrong with using cement to hold it in. If you go to some countries around the world, they cement them in place, and they say that stays fine, and we like to do it with cement. Most people use what's called an uncemented or what's called a press fit implant. Then we put a new ball on top of that, which fits into a new socket. Now, your socket is the hip cup, they call it, and the ball fits in the socket to give you a new joint.
It's so. I mean, I was playing with it earlier. It's like ice. It just glides. It's so amazing.
Well, and that's because what's called the bearing surface is different. You can use what's called a metal ball.
Which one's better?
Well, plastic is the big wear problem. So the cup is lined with it has a metal outside. That's the cup, but the liner is plastic. And in plastic, the wear pattern of this, called ceramic, is less than it is against metal. So a plastic wear pattern is what's going to wear out over time, like your brake shoe pads.
Yeah.
So if you use ceramic, there's about 1/10 of a micron of wear per year. You have to Google a micron. It's not much. So this will never wear out in your lifetime because of the gliding smoothness you talked about before. So if your doctor chooses to use a ceramic ball, that's a good question to ask. Most do, because we talked about the ability of that to prevent wear in the cup. So your hip's going to last a long time. We're going to talk about longevity a little later, but it's not going to wear out because of the ball and socket alignment. It's going to wear out if you run, if you jump, if you fall off a pickup truck and break your femur, or have to have it redone because of things like that. So it's a fake joint. We want people to have it last a long time, but I'd like to talk about how we're going to get in there to do this surgery. Once you're in the hip, like being in the house, whether you came in the front, the side, or the back door, you're in the house, right?
Okay, yeah.
So now, instead of focusing on the surgery, let's talk about how do we get there, and why does somebody want to do an anterior hip versus a posterior or a pocket incision in the back?
Well, can I ask a real quick question before we talk about that? How long does a hip replacement last? Once you put me under, how long am I under?
Well, a hip, you mean how long is the procedure?
Yeah.
Oh, it usually takes about an hour.
What?
I mean, an hour.
You think it would take hours?
An hour and a half if you're. I mean, you have to talk about the time to get in the room, have the anesthesia doctor bop you on the head or put you to sleep, right? Sometimes they do a thing called a spinal. We talked about putting your legs to sleep with a nerve block. The surgeon wants a non-moving target. How it's accomplished is up to the anesthesia doctor and you to talk about. So they'll either put your legs to sleep or put you to sleep. That takes a little while. We talked about the table. The table we use for an anterior hip has little ski boots that let you move the legs in different positions. We have x-ray in the room to let us see not only where we put this, but we want to keep your leg lengths even. That's good, because after surgery, if one leg's longer than the other, people aren't happy with that. Then they're not even like your coffee table with the legs aren't even. So the other advantage of doing some of the front incisions, called the anterior hip, is that the back of the hip isn't opened. So you can sit on a chair, sit on a toilet. You can, move the leg in more positions without worrying it's going to pop out the back. And dislocation, or what's called a joint popping out, we talked about shoulders and kneecaps a little bit ago. Those are very big concerns, a little more so with what's called the pocket incision. So there are precautions for 6 weeks if you have the posterior approach done, where they open the hip from the back. You have to make sure your rump is higher than your knees. You can't cross your legs. You got to hope you're not stooping over to pick up a $5 bill.
It sounds like I wouldn't want to do that. It sounds like if I can have 3 doors, why wouldn't I pick the good door?
Well, that's a good question. First of all, there are more complications in an anterior hip with inexperienced surgeons. There are more fractures. There can be more infections if the surgery takes longer. It's a little harder to do. It's a learning curve because it's a newer procedure. Yeah. So your surgeon needs to be well versed at doing the procedure.
These are what you do. These are the kind of things you prefer. The front.
I do the front incision. I have been doing it. I did the posterior or the pocket incision for 30 years.
Yeah.
I'm doing this for about 6 years because I think the leg lengths are even. The patient's x-rays look just the way we want them. They're faster recovery. I use what's called a bikini incision.
How big is it?
So the incision's about 3 or 4 inches.
You get in there and do all this with 3 or 4 inches.
Sure. And there's 2 ways the front incision can be done, with a up and down long incision.
Yeah.
The problem with that is when you bend the hip, your incision cuts against your hip bender, called a hip flexor. And the other thing is, if you've seen the average overweight person, their tummy sometimes hangs over the waist. We call that Dunlap's disease, where their belly Dunlap over the waist. So then you have this, fuzzball and belly hang over your incision.
Right.
So sometimes we put a waterproof or a sealed, either a suction sponge or a waterproof bandage on the wound for about 1 to 2 weeks after surgery to keep it covered, keep the cats away, keep the tummy off it. But you can use this for most anybody with enough experience from the surgeon. How the surgeon makes the incision is his preference or her preference. The advantage of the main selling point of an anterior hip or a front incision is that no muscles are cut. We go between the muscles. We then get into the hip joint. The recovery's faster. You walk faster. People are they're off their cane or crutch sooner.
How quick am I up walking?
You're walking that day. Most people go home the day of surgery. And
your wife went from operating room to a car within like a couple hours.
She was out of the care facility in 2 hours, 9:30 in the morning.
That's amazing.
She was the first surgery. And the advantage is you still need a walker or a crutch or a cane because your muscles need to stretch out. I have my patients use them 2 to 4 weeks so they don't fall. They feel good. Their crappy hip has been fixed, much like your sore tooth, right? Once the problem's gone, it feels better to put force through it. Our goal after surgery is to tell you one thing: don't fall. So we want you to have therapy at your house. We go through those instructions with the patients. But there's no reason to be in a hospital if you're not sick. So we do your surgery as an outpatient procedure if you're healthy. If you're barfing and your blood pressure is low, most people spend the night in a hospital or somewhere, and then they go home the next day after therapy. But the main thing to think about with your doctor is, how is the surgery going to be done? What are my precautions and concerns after surgery? Right. I think there's an advantage to having x-ray in the room when I do the procedure. Now I have to wear lead. I have to wear a moon suit. The whole time? Keep infection away. Oh, yeah. These are things you have to pound in with your arm. So we have some, I ended up with a rotator cuff repair of my own a couple years ago because we're hitting a couple hundred times.
And you're hitting this thing to go in there?
Well, we're wedging that in to fit tightly, right? So everybody's a different size. Your shoes are different than someone else's, and your femur is different than somebody else's. Okay. So we fit it just like a shoe. It's something fits you exactly. We want to make it fit tightly, but we don't want to crack the bone putting it in, right? There's an expertise to doing the surgery that any doctor will do from any approach. There's, again, if you ask me 6 months after surgery, is an anterior hip better than a posterior hip? The answer is no. The patients are both happy. In fact, total hip replacement is the number one satisfaction surgery in orthopedics. They're our happiest patients because it's so much better than it was. A knee, we'll talk about knee replacements, and those hurt when people bend them. If you don't bend them, they get stiff. So a knee replacement recovery is much harder than a total hip. So, we try to educate people on what to do, what not to overdo, because they feel so much better because their hip has been so crappy for so long. So the goal is do your homework as a patient, find out, am I ready for a procedure like this? Is my lifestyle affected to where, I can't do the things I want to do on a regular basis? Does it keep me from sleeping, getting in and out of a car, shopping, walking? I've got tickets to a ball game and I can't go because I can't walk. Well, your lifestyle is being affected by your crappy arthritic joint. So those are discussions to have with your healthcare provider. Decide how old you are, what is the best option, and then make the decision. Then ask, how would you do my surgery? How many of these have you done? I think that's a fair question.
That's a great question.
If you're going to have open heart surgery, I hope you're asking the doctor, how many of these have you done? Right. Because if you're doing a knee scope, anybody can do your knee scope because it's a simple surgery. You do an open heart or you do a hip replacement or you do a real, detailed spine surgery. You want to pick somebody who really has the expertise for that.
So I'm just curious, and you may not remember, but what's the maximum number of hip replacements you've done in a day?
Probably 4, but we do also knees some days too. So we're doing knees and hips.
So you're going from one room to another room to another room.
We have 2 different rooms because when somebody is finishing a case, they can get the next case ready because they have to clean the room, they have to bring in, take the patient out, bring the new patient in. Got it. So that other case allows more efficiency for the hospitals. People don't have to wait as long. It's like having 2 terminals at the airport, right? one plane would be kind of a slow process. I think the other thing I would tell people is that hip replacement is going to change your life, and it's going to really be a home run for you.
Is there a downside to it?
There's always a downside to any major surgery. Infections, fractures. We talked about dislocation where a joint pops out. There's risks of things like blood clots. If you've had blood thinners, you may need a blood thinner after surgery to prevent one. We don't like people flying or driving within 6 weeks after surgery because your leg's in a car, it's not moving. You have a higher risk for infection not infection, but more for a blood clot or what's called a DVT, where you get a deep vein thrombosis in the leg.
Do you prescribe anything after the hip replacement?
Most people will be on either a blood thinner before surgery, then we just resume that afterwards, or your doctor may prescribe aspirin or a blood thinner, usually a pill like Eliquis or Xarelto. There's a thing called warfarin or Coumadin. Sure. There's a lot of them out there. Those are good questions to ask on your checklist. The main thing is to do your homework. I would leave you with one caveat on hips. like any major surgery, ask 5 people to give you 5 names or 3 names. And a few names are going to come up on everybody's list.
You mean doctor-wise?
Doctor-wise. Those will be, in your area, the person for that surgery that I think, or they think, is really the person to go to. Because, your nurses know, your technicians who hand the instruments know, the reps who open the implants know who the really efficient doctors are, who do a great mitral valve surgery on your heart. I mean, those are things that are worth doing homework for. You don't have to go to the Mayo Clinic to get your hip done. Okay, there's a lot of really good people that can do that. Okay, so nothing against the Mayo Clinic, pretty nice place. But I'm just trying to tell people, do your homework, find out how the approach will be. You'll see some little pictures during this presentation of the implants, the different approaches in the front or the side or the back.
Right.
Ask your doctor what he prefers. There is a muscle that lifts your leg called a glute tendon. We'll talk a little bit about those in another podcast. But if that's torn, then you may want the pocket incision because you want to fix the torn muscle that lifts your leg, much like a rotator lifts your arm. So in those cases, I do the posterior approach because I want to fix the hip, but also fix the torn muscle. You can't get to it from the front, anterior incision. And the last thing I'd say is enjoy your new hip because it's
Here's your keys. Enjoy your new hip. It's like a new car. Drive safely.
Don't fall.
Don't fall. So one question I want to ask, but I think I'm going to ask it because we're going to do another podcast here in a second about PRP and stem cell stuff. Do you inject any PRP into these new hip replacements, or is that just something that's done for other reasons? We talk about
it would be beforehand, not after. Okay. So if your hip has a problem, we're not putting PRP or bone marrow aspirates into your hip. Those are modalities that are done from your blood to delay surgery. They help inflammation. Yeah. They're better than in my opinion, they're better than cortisone or some of the gel things we talked about. But those are a way to delay surgery. In fact, my wife had a bad hip, 8 years ago. I put some stem cells from her bone marrow in her hip, and it lasted her 7 years. She had her hip done last year. Okay. She had it replaced. So eventually you're going to probably need it done. But for her at her middle age, I'll call it, she wanted to wait a while before getting her hip done so that whenever it's done, it should last longer, right? And none of us know how long we're going to be here. So
we're going to talk about that more in an upcoming podcast. But for right now, we're going to sign off on this one.
And thank our sponsors.
I was going to say, don't you want to say something about our friendlies? By the way, I'm getting ready to use Ted's salad dressing today. I'm going to be making chicken on the grill. And it's the only way to go.
Well, yeah, tedsaladressing.com. It's a great Greek natural dressing. It's preservative and gluten-free, sugar-free. And it's a great marinade, but it's also obviously a salad dressing. Yeah. And then the Stiefel GWR Group, our financial advisors that'll help with portfolio planning. There's been some rocky days on the investment markets worldwide, really. So if you look up some of our contacts on the website, you'll see that. And don't forget to thank the sponsors, but also support the Bone and Joint Playbook. Like it on social media. Ask a friend to listen to one of our podcasts.
We're very big in Luxembourg, aren't we? We're like
Frankfurt,
Germany. I knew there was some. Say our friends out in Frankfurt, Germany. All right, folks. This is it for the Bone and Joint Playbook with Dr. John Urse. I'm Terry O'Brien, your producer, and we'll see you all real soon. Thanks.